Why did we need to do a randomized trial? Remember, I started by talking about the observational studies. It's because really, only with a randomized trial can we be able to truly tell if using that particular method does lead to an increased risk of HIV acquisition. It will provide us with the highest quality evidence that will enable women in the future to make truly informed choices. It will also give us information that would allow us to have very clear counseling messages, and will allow policy and programmatic decisions to be made in the light of the data and of the results that we will eventually get. So what is it that we think that the ECHO study will tell us? And this is important. ECHO will be able to tell us because it will compare between the three different groups. Women who are on DMPA versus the IUD, women who are on implants versus the IUD, and women who are on DMPA versus the implant. We will be able to tell what is the incidence of HIV of each group compared to the other. Each of the three groups, one compared to the other. We do have some studies that are ongoing that are looking at the possible biologic mechanisms that may be able to explain to us whatever the results are that we will find. We'll also be able to compare directly how many women stopped using any particular method at any particular time. We'll also be able to tell how many women got pregnant, depending on the group that they had been assigned to and the group that the contraception they were using. However, ECHO will not tell us about what is the risk of acquiring HIV if you're using one of these three contraceptions compared to if you're not using any contraception at all. Because remember, we do not have a group that is not using any contraception. These women are in one of the three groups, and so each woman who was enrolled onto ECHO is using some kind of contraception. So we will not be able to say, how can you compare the risk of HIV acquisition when one is on a contraception compared to if they are not using any contraception? There are other contraception methods we have not tested in ECHO, so we will not be able to say anything about them. Whether it's NET-N, whether it's subcutaneous DMPA, other implants, we will not be able to make any comments about those because they were not tested within ECHO. If the difference in HIV risk is less than approximately a 35% increase, then we will not be able to tell because of the way the sample size was calculated. So please remember that the ECHO trial will provide evidence, not a prescription, but it will give us evidence that will enable us to be able to make decisions for individual women who want to have the information and also for programmatic decision making. The question one may ask is, what does a 50% risk mean? Because that's what ECHO is powered to be able to tell us. If you think about it, prior to starting ECHO, if 100 women were followed up in the trial and 4 of them acquired HIV in any given year, a 50% risk would mean out of these 100 women, instead of 4, we would have 6 women who would end up acquiring HIV. So that's what we'd be able to detect. So this is thinking through what are some possible ECHO outcomes. Please remember, I do not know the results, and these are not the results of the trial. It's simply thinking, what are the possibilities? Number one, we could find there is no difference in the risk of HIV for any of those 3 arms. Whether you compare DMPA to the implant, to the IUD, no difference in HIV acquisition. So that is one possibility that we could find. We are designed so that we're able to tell a 50% increased risk. And the observational data has suggested that DMPA could have between a 40 to 50% or greater risk. So that's why we use that particular sample size. But remember what I said, if it's less than 35%, we may not be able to see a difference. So, what is another possible outcome? What if we do find there's a difference in HIV risk, but if the suggested risk is not for DMPA, but it's for the IUD or the implant? While this would be really surprising, Remember that we don't have enough data currently on any of these methods, so we just don't know. We have the statistical power to be able to detect at least a 50% increased risk for any of these two other methods compared to the others. So this is a possibility. It would be surprising. We are powered to be able to show a 50% increase in this risk. So what is next? Now that I do not know the results, but I've provided you with some possible scenarios about what could possibly happen, data analysis is currently ongoing. And as I said, we are very close to the mid of 2019, but we are not quite there yet. But when we do get there, the results will be disseminated. We are hoping that these results will also be presented to the WHO. WHO, Department of Reproductive Health, has a steering group who is able to look at, they convene independent scientists from all over the world, and they look at the data to be able to make decisions as to what kind of things may need to change or not change about the guidelines. So the information will be provided to them, and WHO can use its normal mechanisms to be able to determine, with this new data available, is there need for any policy change or not? We believe that ECHO will contribute the highest quality scientific evidence on the question of hormonal contraception and HIV risk. And we believe that this information is really needed by women so that they can make decisions about contraceptive use, and also that it will help programmatic decisions and policy decisions about contraception and HIV and programmatic implementation. As I said when I began, there are many that have contributed to funding ECHO. It has been a challenging and an exciting trial to be part of. And we do believe that it will give us the evidence that we need to finally, we hope, lay the ghost that has been around us to rest for a long time. And with that, I would like to thank you very much for your attention. And I'd be happy to take questions so long as you don't ask me, what are the results? Thank you very much.
Do you want to take a seat and then I'll just... Great. I thank you, Elizabeth, for actually putting us back on time, which is terrific. So let's just see hands. This is an important... So I see one there. I'm going to take 3, Elizabeth, in the first round, 4 over there, and then I see a hand over there. If we can get another number, just all on the left-hand side. So let's start with number 3. If you can please just say who you are. And I'm going to stick with Elizabeth's rules of engagement, which is 1 question at a time, just so we give lots of people chance. So 1 question, please. Number 3.
All right. Hi, my name is Shreyoshi Mukherjee. I am from Chai. I work at Chai Swaziland. My question to you was on the research design. What was your unit of randomization? And the different treatment arms that you said, was that a contraception that you were promoting in that treatment arm? In which case, why can't you have a control arm where you do not promote any of the treatment arms that you have, or any of the contraceptions that you have?
I'm really struggling to hear your question. You need to
I heard, so Elizabeth, so if I can just, in the interest of time, say it. So what was your unit of randomization? And can you just expand why a control arm was not possible in that randomization? I think I've represented that sufficiently. Number 4, have you got that, Elizabeth? You okay? Number 4?
It's okay. The same question.
Go ahead. Oh,
it's the same question.
Okay, number 1 then.
Thank you for the presentation. My name is Godwin Nunu Mensah. I'm coming from Pantan Hospital. My question is, assuming all these women are having unprotected sexual intercourse with infected men, what roles is the various family planning methods going to play to increase or decrease their susceptibility to HIV?
Okay. Number 3.
Yeah, my name is Tapio Kujinga from Zimbabwe. I work for an organization called PATAM. My question is almost similar to the last gentleman, but what I wanted to find out is, were all these women at risk of acquiring HIV? And if, they were truly randomized, are you going to adjust for risk of elevated HIV transmission?
Thank you. So, Elizabeth, do you want to tackle those?
Yes, I can certainly try and tackle those. And the nicest thing about some of these questions is that I have Tim and is Helen Rees in the room?
She isn't yet, but she will be here.
Okay, so I have champions who are part of ECHO who would be able to help me answer questions that I might be struggling with. One of the things I love about research is that, I can actually say I don't know or I'm not sure, and it's fine because I'm a researcher. So if I don't know, I simply don't know.
Correct.
So the question is, I think the first question was about the unit of randomization. I'm not sure what you mean by the unit, but we randomized 1 to 1 to 1. There were equal numbers in each. And the way the randomization, they were equal, 1 to 1 to 1, meaning equal numbers of randomization for each of the 3 groups. And you ask, why didn't we have a control group? It's very hard if a woman is coming in and telling you she does not want to get pregnant, to say, you know what, we are not going to randomize you to an effective method of contraception because we want to find out if, you might acquire HIV. They need a contraception because we are focusing on women who do not want to get pregnant at that point in time. So putting her at risk of pregnancy when she doesn't want to get pregnant would not be an ethical way to go about it. Were they at risk of HIV? The fact that they were having sex, which is why they needed a contraception, that definitely put them at risk for HIV. Especially when people have sex with partners whose status is unknown, and not all of them had partners who had been tested. And remember that your partner's status today may not be your partner's status tomorrow. Just because they were tested today, you don't know what else happens in between today and tomorrow. So yes, they were at risk. The last 2 questions had something to do with the women who were randomized, or who were enrolled onto the trial. Did they have unprotected sex? Again, I'll take you back to the fact that these women were looking for contraception or were interested in contraception means that they were having sex and that there was a possibility they could get pregnant. Now, we know pregnancy and HIV, when it's heterosexual, it's the same root of risk. So yes, having sex can make you pregnant. Having sex in the same way can make you end up with HIV. So there was risk. The question that was asked related to this is, was there anything that the family planning method was increasing or reducing? Now, this is the whole reason, this is the crux of the matter why we're doing the ECHO trial, to find out exactly that. For these contraception that these women were using, does any of them, and this is the results we'll be able to hopefully release in the next short while, is there an increased risk of HIV acquisition when you compare these 3 arms? We'll be able to look at women in each of these 3 arms and look and determine how many ended up getting HIV infected when they were on a specific arm. Please remember that for all the HIV trials that are done, ethically, you must do everything possible to provide them with the most comprehensive package that you can. It includes counseling. It includes the regular testing. It includes provision of condoms. And as I indicated, when PrEP was available, women were counseled and provided with PrEP. So the goal is prevent it as much as you can. And then what we end up measuring is that human factor that sometimes makes it impossible for people to perhaps do the best that they can to protect themselves. But we did everything possible to protect these women from getting HIV.
Thanks, Elizabeth. And I just reiterate that there are some sub-studies, Elizabeth did say it, but just to make that clear, ancillary studies that are really trying to unpack the mechanism. And so in a subset of women, more invasive samples were taken, such as swabs and various other things, to take it back to the lab and try and understand what might be happening in terms of inflammation or whatever. So hopefully lots of information will be coming. I'm going to have just 2 more short questions, and we're going to keep it very short. So 1 and 3, and then we'll call it a day. So number 1.
Thank you. My name is Bene from JSI Ghana. I think that the initial observational study related to DMPA. I was trying to understand what exactly does the DMPA do to the woman who takes it that makes that woman at risk to HIV infection?
Thanks. Number 3.
I'm Sani Sulaiman from Nigeria. I just want to ask, when the result does come out, remember, you don't know the result, I don't know the result, but when the result does come out, how would you be able to distinguish between the risk, whether the risk of getting the HIV is actually due to some other factors, apart from the method of contraception,
Great.
like viral load, result of the partners and all that.
Thank
so how
you.
would you be able to distinguish whether
Thank
the
you.
risk of
Great.
acquiring the HIV was as a result of some other factors
I
apart
think
from...
we got it. Thanks so much. Thanks, Elizabeth.
Thank you very much. Your questions go right back to the heart of the reason the ECHO trial was important. And let me start with the last question. The reason we'll be able to tell is because this is a randomized study. That's why we could not rely on observational data, because randomization takes care of all those other factors you're concerned about. How do we know that it wasn't the viral load, it wasn't where they live, it wasn't anything else, what they eat, what shoe size they have, whatever else you want to imagine. The randomization equalizes that. It takes away all the background noise and allows us to be able to figure out that it is the use of that particular product that enabled us to be able to compare them. Without that, it is impossible, because then we have a lot of confounding, and that's what the challenge was with the observational trials. The other question from my colleague from Ghana, again, this is the very reason why we needed to do this trial, exactly what you're asking. What is it? Is there something that DMPA is doing to increase that risk? And the question we answer is there that increased risk linked to DMPA? So this is actually the heart of the reason why this study has been done and why it is important. Thank you very much for asking.
Thank you, Elizabeth. I think fantastically handled. And I really appreciate all of you. I'm intrigued that most of the questions came from our male counterparts here. So hopefully this dialogue will continue about the importance of contraception, women's choices, women's rights on this continent. So thank you for your participation and your engagement. And Elizabeth, stunningly done. Thank you so much. I'm going to hand over to the next session. Don't move. You just got to stay put.